Hi, everyone. I hope everyone can hear me well. So welcome to the educational webinar of the GliMR. I hope everybody knows GliMR, but if not, we work in MRI and glioma. We work cost action, and we're now a working group of ESMRMB. This is a series of webinars that have mostly an educational purpose. And we'll start this first webinar with the team AI in glioma. I ask the participants to put your name so we can keep track of the participant list. And I think, well, we can start. The first speaker will be Brian Liu. He's from Oslo University. Maybe I'm gonna stop sharing. So easier. So he's a researcher in the CRI group at Oslo University, where he develops clinical deep learning solutions for medical image. He holds a PhD in AI from Utrecht Machine Learning Group and the Norwegian Computing Center. His research focuses on developing robust deep learning methods for medical computer vision and multimodal data analysis. Committed to translational AI, he works to bridge the gap between algorithmic innovation and clinical implementation to improve patient care. And today will tell us about his work on treatment-aware diffusion probabilistic model for longitudinal MRI generation and diffuse glioma prediction. So I think Brian, you can start your presentation.
Okay, thanks very much for your introduction. Can you hear me?
Yes, perfect.
Okay, great.
Yes.
Now I'll start to share my screen. Yes. Here we go. Let me see. Okay. Hello, everyone. Good morning. Yes, my name is Brian Liu. I'm a researcher from the Oslo University Hospital and the CRI group. So today I'm very happy to present our work. It's about a new model called treatment-aware diffusion model for MR generation and glioma growth prediction. This is a collaboration with Elies from Valencia University, Spain, and many of my other colleagues at OUS. Okay, let's get started. Here is a quick roadmap for today's talk. I will start by defining the core problem we are trying to address and providing some background. Then I will take the main portion of the talk to try to unpack the details about the TADIF model we proposed. I will also briefly review how diffusion models work and then highlight our specific innovations. After that, I will show some results and experiments to show what the model can do, and also finally to give a brief discussion about the model's limitations and give some concluding thoughts. Okay. So what is the core problem? We are focused on the post-operation diffuse glioma's evolution. As you can see from this visualization, gliomas are incredibly dynamic. They are the most common and the most aggressive type of brain tumor. So they are super difficult to treat because they grow and spread through the whole brain. This leads to a very poor prognosis, reported with a median survival of less than 15 months. The tumor's evolution isn't simple. It's, as you can see from the animation, in changing volumes and depth can be influenced sometimes heavily by the patient's treatment. A patient might receive chemoradiation treatment called CRT and then move to like TMZ, is temozolomide. It's a complicated words. The tumor will respond differently and individually to each treatment and over time. So predicting such complex and nonlinear interplay between the natural growth and treatment-induced changes is the main challenges we are trying to address. So this brings us to our proposed solution, TADIF. This concept diagram shows an overview of the model. On the left, we feed the model our source information, which includes a sequence of patients' history of past MRI images, saying S1, S2, S3, and along with the treatments and deaths associated with each of these images. We then give the model a target condition, for example, predict what the patient's brain will look like at the day 225 with TMZ treatment. The TADIF model, which is basically a conditional unit variance, then process all this information to generate a new synthetic future MRI images for the given time point. But it doesn't just output images. As you can see on the right, it also generates corresponding tumor masks for both the future generated images and the source images. In the meantime, it also provides uncertainty maps, which tell us where the model is confident and where it is not so confident. Let me see next. Okay. To understand what makes TADIF special, we first need to understand what is diffusion model, how it works. The main idea of the diffusion model is simple and consists of two main processes. First, there's a forward process or diffusion process, which is predefined as a fixed process. You basically start with the clean image X0, and at each time step, you progressively add a tiny bit of Gaussian noise. You repeat this over and over until you left a pure noise. This part is predefined. The magic happens in the reverse part. It's called the reverse process or the noise process. This is a learnable neural network. The goal of this network is to do the opposite, to start with the pure noise and step by step remove the noise it predicts until it reconstructs the clean image again. So the idea sounds very simple. Let's look at the forward process in just a bit more detail. As you see in the top row of the image, we start with the clean MR image and add noise according to a variance schedule, beta t. We need to thank to the mathematical trick called the reparameterization form, so that we can use the formula to jump to any arbitrary time step in one go, just to generate the noisy image in one step. As t increases, the alpha bar, which represents the signal from the clean image, decays towards 0, and the noise term takes over. This plot on the right just visualize this. The noise schedule bar increase and the cumulative signal alpha bar drops off until at the final time step big T, saying like 1000, the image is effectively become a noise. The reverse process where we learned is about it's a learned neural network. We refer to as epsilon theta. Its job is to predict noise that was added at any given time step t. If the network can predict the noise well, it can also generate clean images. Basically, the network just predict noise, then it can be subtracted step by step from the noisier image to slightly cleaner image, like from xt to xt-1. We use the closed form equations as you see here on the top of this slide by repeating this process, starting from a noise at t equal to big T and running all the way down to t equal to 1. We can generate a new and clean image from the noise. This slide just shows that process in a bit more detail. The core of the reverse process is the noise prediction network, epsilon zeta. It takes two things as input, the current noise image xt and the current time step t. It then output a prediction of the noise that was added. This predict noise is then used in the formula to calculate the cleaner image for previous step, xt-1. This is the fundamental generative mechanism of the diffusion model. Basically, predicting noise is equivalent to the predicting the clean image. So how do we train this learnable network? It's actually very simple. You first take a real and clean images from your dataset. You pick a random time step t. Then you use the forward process formula, creating the noisy version of xt. You also know the true noise that you added. You then feed xt and t into your neural network and ask it to predict the noise. The network makes its prediction. We then calculate the loss, typically the mean squared error between the true noise and the predicted noise. We then compute the gradient on this loss to update the neural network's weights. You do this millions of times, then the network becomes very clever and becomes incredibly good at predicting noise. And as a byproduct, it's also good at generating images. Okay, that was our primer on standard diffusion models, or DPMs. Now, what did we do differently in TADIF? A standard DPM diffusion model, as shown on the left, is unconditional or only conditioned on the time. It just learns to generate random new images. It is not what we want. We want to control the generation. Our TADIF model, shown on the right, is highly conditional. We don't just feed the network to the noise feature, image xt, and the time step t. We also feed the entire sequence of source MR images and the treatment-aware inputs, and the depth for both the source and scans. Also, our model output is different. It doesn't just predict noise. Simultaneously, it predicts two things: the noise and the tumor masks, denoted by amplitude. And the loss function is also different. We don't just minimize the noise loss, we also add a segmentation loss and force the model to learn to generate both the images and as well segment the generated images as well in the same time. So this slide just give you a clear version of those inputs and outputs. The input is on the left are the stack of source MR images, S1, S2, S3, maximal 3 history images can be stacked into the noise filter images XT. You see the treatment and death information, which encoded fed into the model at a different stage. The model then output two things: the predicted noise, which is used in standard diffusion to get a cleaner image XT-1, and the predicted tumor masks. At the final detail, as a final detail, this predicted mask is actually fused over the last few denoise steps, the last TM steps. Default, we choose the last 10 steps to create a more stable and accurately final segmentations. It's called M0. To test our model, we used the two main datasets. Our local dataset called Cellar. They basically contain 23 patients with a total of 255 serial scans. We use 80% of them for training and 20% of them for testing. And also we used the dataset called Lumia dataset. This dataset comes from a different institution. We use the external dataset to measure our model's generalizability. So you can look at these two data that can be publicly downloaded from the website. So first, we look at the task for future MR generation. The quantitative results are quite good. On our local test, we achieved a SSIM, its structure similarity index score is about 0.991, and a peak signal to noise ratio, PSNR, is about 27.9. And the MSE is mean square error is about 0.974. It looks very good. And on the external test, the model hold up very well, I think. We saw only a small expected drop in performance. For example, the SSMRM score drops about 7%. This is I think it's a good result for external validation. It shows the model is robust and not overfitting our local set. These slides, we are looking at qualitative results for different patients test. The present column shows the history column shows the last real MR images we gave the model. The target column shows the future day and the treatment we asked to predict. The prediction column shows our TARDIF model generated, and the ground truth is the actual MR image from the future day. As you can see, the model does a generally good job. It can basically to correctly predict stable tumors and the shrinking scenarios, and also can predict the tumor growth. It's not just getting the category right, it's also capturing the shape, location, and intensity of the new and changing tumor regions marked with the yellow or marked with the green or violent colors in this picture. This is very promising, I think. We also evaluated tumors prediction tasks. On the top left, you can see the average dissimilarity coefficient for the future tumor masks was about 0.72. I think This is a solid result considering a full automatic prediction task on the future longitudinal problem is not bad. And the left bar chart just shows the correlation between the predict volume with the ground truth tumor volume. For most day regions and the patients and treatment, the correlation score is pretty high, mostly above 0.9. But there are two edge cases, patient P1 and patient P2. These two patients are kind of, the patient one is underwent a secondary surgery during the follow-on period. An intervention that was not represented in our training data, thus could not be predicted correctly. And the patient 2 was diagnosed with secondary glioma type, which was a rare subtype that was underrepresented in the training set. So they highlight the model's current limitations. As a data-driven method, its performance is fundamentally dependent on the diversity and the completeness of the training data. So, well, here we just show some limitations about this model. First, as I said, our data set, while high quality, but it's quite small, only 23 patients, it's not enough to capture the full spectrum of the glioma variants and the growth patterns. This was evident in the difficult cases like patient 1, patient 2. The clear solution here is to move towards multi-institute data sharing to cover more data set in future, cover more rare cases. Secondly, is the computational cost. The diffusion models is knowing slow to sample from. The inference process, which requires hundreds of denoising steps, is not yet very fast during sampling. But it can be overcome in the future with advanced sampling algorithms. Lastly, our model operates on 2D slides now because we want to maximize our training samples. So the next step is we want to move to a full 3D model that can capture the tumor's spatial context even more accurately. So in conclusion, today we just present our new model TADIF, treatment-aware diffusion model that represents, I think, a promising advancement in glioma growth prediction. By deeply incorporating the treatment information into the diffusion framework, it can overcome some limitations of previous data-driven approaches. We've shown that TADIF can generate realistic future MRs and also can predict the corresponding tumor masks, evolutions, and with uncertainty maps. We believe that with the more depth and further refinement, the TADIF diffusion model has the potential to become a valuable tool in the clinical settings, like supporting improved personalized treatment planning for glioma patients. Here is the reference we used for this talk. I'd like to thank the fundamental work in this area, especially the original denoising diffusion probabilistic models paper by Ho and his colleagues, as well as our own paper on this work. Yes, this is today's talk. Thanks for all your attention. I would like to answer any questions, and the full paper and the code is available on the GitHub for anyone who is interested. Thanks.
Thank you very much, Brian. It's very, very nice, mostly an excellent presentation. So just as a note, we will keep the questions for the end of both presentations to have more time to discuss. And now we will move to our second talk of the session. It's an honor to introduce Prajwal. He is a PhD candidate at the School of Biomedical Engineering and Imaging Sciences at King's College in London, where he conducts his research in AI application on glioma imaging and genomics. He is currently working as senior neurosurgery registrar at King's College Hospital, and today his presentation today is titled Radiogenomics AI Models Predicts Cancer Immune Gene Signature in IDH-wildtype glioblastoma, PRECISE-GBM study. Prajwal, thank you very much for joining us. Please, the floor is yours.
Thank you. Thank you for the kind introduction. Let me just share my screen and we will start. Okay. Right. Can you see my screen now?
Yes. Yes.
Okay.
Perfect.
Right. We will be talking mainly about my part of my PhD project, which is this study about combining radiomics and genomics from IDH wild-type glioblastoma to try and predict the cancer immune signature using these AI models. So for this talk, I will first talk about a few things about what's the current landscape of glioblastoma immunotherapeutics and where we are at that. And I'll briefly talk about radiogenomics and how it works. And then I'll mention about the 3 AI models that I have been working on for the last 4 years, and some few things about how we can translate into a clinical scenario. Don't have any disclosures for this presentation. So we'll start with the current landscape. So if we look at this slide, it's a very busy slide, but if we focus on the side here, it gives us 4 main categories of treatment methodologies that have been utilized for immunotherapy in glioblastoma. So immune checkpoint inhibitors, CAR T-cell therapies, cancer vaccines, and oncolytic viral therapies. But with the recent trials, the individual therapies have not shown much benefit, but there is some subgroup analysis which has shown benefit to a certain group of patients, and thus most of the trials are now moving towards combination therapies to try and see if we can do some tumor regression. The main reason and challenges for these is the mechanisms behind the immunotherapy and is that the immunosuppressive tumor microenvironment that glioblastoma has, and the major players, as we know, are the various cell types that create immunosuppressive microenvironment, as well as the various characteristics of the GBM cells and the blood-brain barrier itself that makes it challenging for the drugs to act. I was lucky to focus on the immunosuppressive side of things, the cellular component of the immune microenvironment, which we will talk further about predicting these scores in the tumor itself. Coming to radiogenomics, so we know radiogenomic combines radiological imaging data and genetic data. And for that, you would require some sort of very advanced statistical or AI models to try and link those macroscopic and microscopic information. So in terms of data domains, there's an example for high-grade gliomas. So you can see from imaging point of view, the standard MR imaging, as well as we have the advanced imaging like PET scans or other metabolic scans, as well as some functional imaging. So these are the main imaging part that are being utilized for glioma. And from that, we can then extract some image-related features. It could be radiomics, or it could be something directly from the deep learning methodology to extract the pixel-based and deep features. In terms of the genomic side of things, if you look at this part of the picture, so there is RNA, DNA sequencing data, data related further downstream from proteins or proteomics and metabolomics, as well as huge rich data coming out from histopathology. that gives a detailed information about the ground truth, as well as emerging evidence coming out from liquid biopsy, as well as intraoperative Raman histology data. The DNA contributes a lot to epigenomics and genetic alterations. So these all forms the genomic side of things in radiogenomics. And in addition to that, there is longitudinal data as well, as discussed by Brian before in terms of imaging. So where we can apply this, so I put this for as a flow of patient pathway where patient undergoes various treatments and diagnostic methodologies during their route in treating these high-grade gliomas. So starting with diagnostic imaging all the way down to immunotherapy. So my focus has been on the first part of this graph, utilizing the diagnostic imaging, and we're trying to predict the immune status directly from the diagnostic imaging, so that we will have an early information regarding what is the status of these patients even before they undergo surgery, so that a well-planned strategy can be made even for like immunotherapy early on, or a new adjuvant treatment, or even for adjuvant immunotherapy. We began with some questions when we started this project. So the questions were how, given that there was failure of this in a lot of immunotherapy trials, what would be the better way to do it, or how can we better select patients for immunotherapy for glioblastomas? And that then brought us the clinical question, how better to select patients for these trials, and how to better identify responders. We, in the meantime, then performed a literature review to see if there was any further studies being done to identify these biomarkers from imaging. And so we looked at all the MRI-based study that looked at identifying some features and biomarkers related to immune system within these glioblastoma tumors. And we were able to identify that, out of these 9 studies, 5 of them were using radiomics. And we did then come to building a question about machine learning, so how to build a classification model that can give us an idea about responders versus non-responders. So this was the starting question. So this then led us to build this study about making a classification model based on radiological biomarkers that can then give us an idea about the immune status within these tumors at the time of diagnostic MRI, and that led to PRECISE-GBM study. So we designed this with the help of open access data from multiple centers around the world, and thus retrospective in nature. So we were able to curate the largest data set, open access, available in the world, of around 176 patients that included data coming out from North America, Europe, and China. So a multi-center, multi-continent data, which is all open access. And from the MRI data, we were able to then extract radiomics features. So these are the pixel-based data that comes out from MRI. And then we utilize the other half is the transcriptomic data from genomic side of things. So to build that, the ground truth or the labels, we use these transcriptomic data that came out from RNA sequencing and microarray data. We did have an issue about some of the images in the data set, that there were some missing sequences. We wanted to utilize all the 4 sequences, the standard sequences that we do for glioma imaging is T1 post contrast, FLAIR, and T2 images. And also the constraint was that our segmentation model required these 4 sequences to be as an input, and thus we had to make some changes for the missing data so as to avoid losing a lot of data sets. So we then looked into synthetically generating these missing FLAIR sequences, which I will be talking later down the line. And during the validation process, so we performed a few tests, some statistical methodology to try and see if we can produce a robust model. And that included a simple train validation, followed by a 10-fold cross-validation, And that then proceeded to leave one out cross-validation and ultimately a cross-cohort held-out strategy so that we can see if the models were stable enough and we're able to generalize in a completely separate held-out data set. Bootstrapping was used in the end to try and see if we can select the models out of the multiple models that we tested on. So this slide gives an idea about the data sets and the matching that underwent between the MRI and the transcriptomic data. So each patient had a image data set and transcriptomic data matched together from the same patient. The transcriptomic data came from tumor tissue extracted from surgery, which then underwent sequencing to give us this transcriptomic data. That they were harmonized, and then the labels were extracted from transcriptomic data, and the radiomic features were then selected from the imaging side of things. In terms of the data set itself, so these are some clinical and demographic features of the data set. So we had altogether 5 data sets, namely TCGA dataset, IB-GAP, CPTAC, Rembrandt, and CGGA dataset coming from China. And we then group these datasets into 3 cohorts, which you can see at the bottom red table. Group 1 had 155 patients, and group 2, 141, and group 3, 143. And the rest of the data was held out separately, and the cohort itself was used as a held out data set. So for the first group model, IV-GAP was the held out data set, whereas for group 2 was TCGA and for group 3 was CPTAC data set. So these were held out during the testing phase. Now I'll talk briefly about the synthetic image model that we built in the process that helped us tackle the missing flare sequences. So this was a GAN model, which is called a generative adversarial network, which basically does is if we supply the model or train the model with 2 different sequences here, the T2 and flare image were utilized to train the model to try and see if we can generate a flare sequence. So the model can learn from the T2 image as well as the target flare image and ultimately produce an output of flare sequences. So the ultimate input for these trained models would be a T2 sequence, and then you'll get a flare sequence out from that model. And we were able to generate all those missing sequences with this model and then utilize that for segmentation followed by extraction of radiomic features. So we called it a PRECISE-GAN model. The GAN model itself is based on a PIX2PIX design and architecture that's an open access model available for download for everyone at GitHub. Now we move on to the first step of analyzing the images, where we utilized the deep learning model, an open access model again coming out from Bonn, called SD-Glio and SD-Glio Auto. So we utilize that to automatically segment the 3 different regions of these images, all 4 sequences. So we have the necrotic core in red, enhancing tumor in green, and the blue region is the edema region, or the non-contrast region on the flare sequence. This slide gives an idea about how the radiomics were extracted once the segmentations were done. So, there were some pre-processing steps prior to segmentation, the registration, skull stripping, and some of the intricate analysis first before we did the segmentation. And once the segmentations were performed, we extracted radiomic features through these different tumor areas. So we were able to extract features each differently from the necrotic tissue, enhancing tumor, as well as the edema portion separately. So it was the count, we extracted around 1,000 features from each region per segmented tumor per patient. And we again utilized all the open access models that were available to keep it generalizable. And the radiomics were extracted from the Harvard model, that's available on GitHub, and the rest of the pre-processing was done with SimpleITK. In terms of validation strategy and held out strategy, so these were the ones that I made. It's such a way that it's easy to understand. So we did, the initial step was 90% training and then validation on 10%. And followed by that, we again performed a inter-dataset Liu dataset about cross-validation, and also a 10-fold cross-validation on these datasets, produce different results from each of them. And ultimately, what we did was we did a cross-cohort held-out strategy where 3 different models were designed with 3 different held-out dataset, which were harmonized separately and independently, and they were tested on 3 different held-out dataset to see if the models were stable enough, as well as if they could predict on a independent held-out dataset. This figure gives a brief idea about the whole process in terms of number of the different data sets, as well as how the held out cross-validation was done, and ultimately a list of binary labels that we were able to predict with these models. So the labels were overall immune score, as well as of the immune microenvironment, T cells, T regulatory cells, macrophages, different types, microglia, as well as dendritic cells and NK cells. The ground truth here was provided with the help of 2 different signature matrices. One was pan-cancer signature matrix that gave us an idea about the immune infiltration from 16 different cancer types, as well as GBM specific matrix. So that these 2 produced 2 different labels, classifiers, and then we were able to get a total of 17 different classifiers. These classifiers were built with the architecture of 2 different types of models. One was a support vector machine model, and another one was a ensemble model, a combination of support vector machine, random forest, and histogram-based gradient boost models. So that we can at least have a comparison between 2 different types of architecture to see which architecture worked better. This image gives a brief summary of how the model design was done. So we talked about the imaging section where we did the segmentation, then features were extracted. These features were then selected for most important features according to the immune part of the tumor using lasso CV architecture. And this selected features were then utilized to build the classification model. And, in terms of labels, the bottom half gives an idea about how we built the labels. So from transcriptomic mRNA and microarray data, we were able to estimate the immune signatures and overall scores using the deconvolution algorithm from Stanford. And then we were able to build a binary classifier using Gaussian mixture model. And this will ultimately utilized to build that classifier model and produce the predictions. So this is an initial result of the first validation strategy where you had 90% training and 10% validation. And the results are from a support vector machine. So you can see the AUC curves as well as the balanced accuracy curves, which were quite accurate in producing in predicting these various signatures of various cell types and the scores. So they were able to give us an idea about high versus low score. And that was the binary split using the Gaussian mixture models for each cell type as well as the overall score. So we were able to know quite accurately in terms of high scores versus low scores of these individual cells as well as the overall score. When we looked at the 10-fold cross-validation and the confidence intervals, so there was some drop in the various metrics, but still we were able to get quite considerable results even on the 10-fold cross-validation with not a lot of difference in terms of the confidence interval. So there's a good accuracy as well as AUC and specificity for overall immune score. And if we compare that with the ensemble models also, they were able to give us quite accurate results. There was some performance drop with macrophages, which I would understand also in both reasons for having a very different kind of presence in the immune microenvironment, as macrophages tend to change between the early state versus M1 or M2 type of macrophages. So there is a lot of change that undergoes within the microenvironment, and I can understand why the models were not able to predict that accurately. And ultimately, in terms of cross-cohort held out strategy, we had results for both signatures. So this is balance accuracy. This is for GBM signature only, and this is for pan-cancer signature. And we were able to get quite good results for most of the cell types. Some of them didn't perform well on the held out strategy. And we utilized 3 different metrics: the balance accuracy, MCC, and the Matthews correlation coefficient, and precision. In precision also, we were able to get some good scores for some of the cells, but not very good for most of the cells. So ultimately, we were able to then identify 2 main categories that we were able to get a very good prediction out, even with these 3 different held out data sets in these metrics. So both of them were T cells and macrophages, and both utilized the pan-cancer signature matrix. We were able to perform better as compared to the other signature matrix. And the preferred model for T cells was SVM, so which performed better than ensemble models, and for macrophages was the ensemble models. And these are the results. And I have included the bootstrapping results as well, which was statistically significant for balance accuracy for T cells. And still had moderate positive MCC as well as precision and balance accuracy. And there was some favorable results from bootstrapping, although there was not statistically significant. But these were the best models that we could identify. When we plot these radiomic features with the immune signatures, so I was able to build this linkage diagram, which gives an idea about the selected features across coming out from various images and how they contribute to producing or predicting these different types of immune scores. So this is a nice diagram that gives the summary of how these features are linked together. So you can see in the middle column is the image and the area of the tumor. So T1 image necrotic core, T1 enhancing tumor, T1 edema region, and how they contribute to different types of scores. And the thickness of each represents the number of features and the magnitude of how they correspond to each other. The heat map on the other side gives an idea about which image sequence produced how many features. And these are all unique features to these particular MRI sequence, as well as the area of the tumor that contributed to these number of features. So you can see that roughly most of the sequences provided a good contribution, as well as the different regions of the tumor provided good contribution to these features to build these classifiers. And ultimately, coming towards the end, so looking at how we can apply this to a clinical setting. So the idea would be that if we have the images at the stage of diagnosis when the patient comes in for a scan, then we can then use this image through this model. And this model will be able to then give you a prediction of high versus low scores for different cell types. And once we can combine these high versus low scores into a stratification strategy, then we will be able to give an idea of which tumors are likely to have what proportion of different types of cells, and whether they would be responsive towards either immune checkpoint inhibitors, or they would require first changing of the microenvironment, followed by immune checkpoint, or they might require some vaccines if they had high dendritic cell counts. And this is the later half of the project, where I was able to then build a graphic interface utilizing these models, so that it will be more user-friendly in the future. So this is a graphic interface that can input the, so these are the test radiomic features coming out of patients. And then when you do the predictions, it'll give you results of these categories. You'll have immune markers, SVM prediction, as well as the in-sample prediction. And depending on that, also have confidence bars to see if it's actually having a good confidence levels and to see which were high and which were low. And you can even save these plots as well as PDFs and ultimately have a stratification to see which group they belong to. And then I added this extra information
Sorry,
where you...
Prajwal, we need to end to have time for, if you can, 1 minute just for, thank you.
Yeah, I just have one more slide, I think that's fine.
Okay.
So yeah, this is the further work that I've been doing, and I'm moving on to deep learning autoencoder models to do similar things, but utilizing 3D images directly without being dependent on the radiomic features, which is something that I'm working currently and it's being built on. And ultimately, I've summarized a proof of concept radiogenomic model architecture. And this is now, the model will be available soon in GitHub for other research groups to try. And it has a potential to be used as an observer tool initially in a clinical trial. And then ultimately, we will be able to provide a agentic role in patient selection to improve the results of immunotherapy trials in the future. Thank you.
Thank you very much, Prajwal, and thank you very much, Brian. Both of you have presented outstanding presentations. So now we have some time for the questions. So feel free to type them in the chat, and we will just ask you to present your questions. So feel free to write the questions, and thank you for all of you for being here. So anyone has a question? So just for break the ice, I can just ask a first question and give time for, sorry, I'm not seeing the chat. Yeah, sorry.
No questions yet.
No questions, yeah. So I can just start with a first question for Brian. So how might we interpret the uncertainty maps generated by the treatment-aware diffusion generative model?
Okay, thank you, Elias. Yes. So the model's uncertainty map is, I think, is very important because these maps can identify the specific regions within around the tumor where the model's predictions are less confident. This information can be used to inform risk assessment and guide treatment planning. For example, in areas of high uncertainty regarding the tumoral boundaries, a clinician might opt for a more comprehensive treatment approach or just followed by closer monitoring and adaptive strategies. So the model's current capability just provide calculate the uncertainty based on the multiple sampling, just compute the standard deviations. But in future, we would like to incorporation like a Bayes framework to provide a more maybe advanced another choice uncertainty insights. So because this current uncertainty map is just is driven by the data set, we want to in future want to incorporate the models uncertainties. This is the future work. So I think uncertainty map just give you clinical insights how we treat the predict growth patterns. Yeah.
Great.
That is.
Thank you, Brian.
Thank you.
So if anyone has a question, I have
there
some.
Is a person with a raised hand.
Sorry.
Yeah, if you want, you can
of course.
turn on your camera and your micro.
Hi, I am Akshay. My question is for Prajwal. Are there any radiological correlates for those tumors who have better immunological signature compared to those who don't? Is it like more edema or anything like that, which you could correlate from the machine learning features? to the routine radiology workflow? Is there anything you guys could notice?
Thank you, Akshay. I mean, there are regions that provide very unique features coming out from not just the edema, but also from enhancing tumor as well as necrotic core, depending on the type of immune cell. So we also know biologically that there will be a lot of macrophages around the necrotic core, whereas there might be other types of cells in the edema region or the enhancing part of the tumor. So it's not the same. Because these three different regions of the tumor represent different activities within the microenvironment. And we know that these tumors are very heterogeneous. So we did identify different signatures for each type of each region. So edema had a different signature features coming out from MRI, whereas the necrotic core had a different imaging signature that could correlate with these different cell types. So in terms of your question, yes, we were able to identify the various difference in signatures, and they would correlate with different regions. Yeah.
Yeah, thank you. And does that correlate with survival? Sorry if you included that in slide, but I don't know whether that.
Yeah, so I mean, the idea was to get a diagnostic biomarker that rather than predictive. So we're not trying to prognosticate whether that particular patient would survive longer, because for that you would need patients who have undergone immunotherapy specifically. For this data set, we did not have any immunotherapy related data. And the idea of this project was to build something that would give us a diagnostic biomarker rather than a prognostic. But that is the next step that we are trying to do to prospectively validate this with some patients who are going for immunotherapy, so that we can have a prediction early and check if that model predicted the right direction. So that's something that we're doing in the future.
Thank you.
So, thanks. We have a few minutes. We have 3 questions in the chat. So just if we can answer this fast, it will be great to answer them. So we can start with Jacinto Dobon that ask Brian, how does the model behave with very atypical tumors like observed in patient 1 and 2?
Okay. Patient 1 and patient 2 is edge cases. The patient 1, as I mentioned, let me see patient 1 is seems like did follow-up secondary surgeries. So that's why the model couldn't predict, because the tumor was removed by surgery. So it's not a normal treatment, not like radiology or chemotherapy. So the model didn't train like this. For another patient was on, it was diagnosed as a secondary gliomas, because our training set is mostly focused on the new gliomas. It's not a secondary glioma. Secondary glioma may behavior differently. Evolution may have different patterns. So the model didn't train on enough these rare types. So that's why the model's performance drops very much on these 2 types of patients. But in future, we want to gathering more data set, covering more like secondary gliomas and maybe more treatment types. Now the model only trained on the CRT, the chemotherapy and the chemoradiation, 2 types treatment. In future, we need more like a treatment types incorporated in the model. Maybe can improve the model's performance. Since now this is the current model's limitations. Yeah. Should I?
Right.
Yeah.
So then we have, sorry, Marta, if you want to.
I was going to ask the question from
Yeah, so.
I think it's for Prajwal about the radiomics classifier models. How can we ensure that radiomic classifiers are robust and not overfitting, especially when data sets are small or heterogeneous?
That's a very important question. So what we did in our case is the way we designed the data structure as well as the model design both addresses these in certain extent. We can't really 100% avoid that. But what we did is, because the data is very heterogeneous, so we took data sets coming out from different centers, different manufacturers, and different Tesla strengths. So the MRI were not just one particular type of manufacturer or one particular type of Tesla. So there was 1.5, 3 Tesla images. There were manufacturers from all around the world. So we utilized that to bring some heterogeneity within the test data itself, although the numbers were small. And then in terms of the transcriptomic or the genomic data, also, we did the same thing. So we did not limit this just for RNA sequencing, but we also utilized microarray data, which would give similar kind of information, but slightly different technique of how it's done. And also the techniques of extraction or machine used for sequencing were also different for different data sets. So that gives a variability within the training data set itself. And number two, in terms of model design, what we did to address that problem is to stratify when we were selecting the 2 different classes or building the binary classifiers. So we were stratifying for the lower class also to give some extra weight if the number of patients we had lower class or high class were smaller. And also what we did is, rather than just having a median or a very strict metric to classify the 2 labels, we use Gaussian mixer models because we didn't know what would be the normal distribution or the abnormal distribution for these differences. So we use some machine learning advanced statistical models to predict the difference or divide that into binary itself. So that gives us a bit of variability to try and address that overfitting part. Yeah.
Great. And finally, I don't know if we have time, but if we can ask this fast. Teresa asked if, in the case of the model presented by Brian, we have used perfusion data, and if not, if we have any insight of how the inclusion of perfusion may impact on the uncertainty maps presented. So if it could contribute to a better model performance.
Okay, so this is difficult questions. Actually, I would not very. I'm not expert on the perfusion images. so now, because perfusion images sometimes like if I understand correctly, is like a dynamic enhanced like perfusion DCE, right? Or something other like MR.
I think probably Teresa wants to know if we include the maps already processed perfusion data, just the CBB maps or the CBF maps.
It's not like
no
stuff. It's just the CVB. It's I think it could help for the model in but we this current work just preliminary test the diffusion model's capability. But in future, we also want to like add this kind of CBV, CBF, this kind of information, and also as well to include maybe other types of informations as a conditional to guide the diffusion process. But the importance is that you must have enough data set to train model. If you only have a few cases, like a few diffusion maps, it couldn't help anymore. You have to accumulate a lot of diffusion maps, training examples. Then you can improve the model's capability to predict the progression of the tumors. I think it's beneficial in future to incorporate perfusion, any kind of perfusion maps.
Perfect. So we want to thank our speakers for the presentations. We want also to thank all of you for attending and also for granting permission to record this webinar. So I don't know if Marta or Teresa wants to add anything. We wanted to thank the Educational Taskforce of the GliMR for organizing this. And I think that's all for today.
Yeah, I'll just add that if anyone wants to know more about our events, they can follow us at the social media. I've posted in the chat.
Great.
Thank you very much.
So Thanks all for being here, and see you in the next webinar.